All right. Thank you, everyone, for joining us today for the very first Michigan Cardiac Rehab Network Telehealth Forum. My name is Emily Bear. I'm a Site Engagement Coordinator with MVC, and I am very excited to have you here and a part of this conversation today. We will be recording this session, so please keep yourself on mute unless you're asking a question or contributing to our discussion to ensure an optimal recording. Today's agenda will begin with a brief introduction to MiCR's telehealth initiative, followed by a note about recent legislative updates impacting virtual cardiac rehab reimbursement. We'll then hear from members from Henry Ford Health and Michigan Medicine, two Michigan cardiac rehab programs offering virtual options to their patients to learn a bit about how they got their programs started and their current program structures. As questions arise, feel free to add them in the chat, or you may hold them until the second half of our session when we'll open the floor for discussion and Q&A. All right, before we begin, I do want to send a thank you out to our MiCR Coordinating Center team for collaborating and bringing this forum to you today. Our co-directors, Jesse Golbis and Mike Thompson, will be leading the discussion portion of today's session. As a reminder, MiCR is a statewide collaborative led by BMC2 and MVC with a mission to equitably increase cardiac rehab participation for all eligible individuals in Michigan. Since the launch of this partnership, we've seen cardiac rehab participation rates for the main 5 conditions increase across the collaborative from 24% in 2020, and 35% in 2024. But as you can see, there is still a gap to be closed in this care. As part of MiCR's 2025-2027 strategic plan, we're exploring new ways to support cardiac rehab programs across the state. And one key area of focus is telehealth. Our goals for this initiative are to understand how telehealth cardiac rehab is implemented across Michigan, to identify real-world successes and challenges in telehealth delivery, and to use data and feedback to guide the development of toolkits, training, and best practice sharing. But before we jump into creating new tools or resources, we really wanted to pause and learn about the current state of telehealth cardiac rehab in Michigan. To better understand this current landscape, MiCR conducted a short survey focused on how cardiac rehab programs are using telehealth and how leaders and care teams feel about it. The survey was shared with all MiCR member programs between August and mid-December of 2025. We heard from 25 cardiac rehab centers representing 7 large hospital systems from across Michigan, and their responses offered a helpful snapshot of where programs are today. Many of you are probably on this call right now. As you can see on this slide, only 2 respondents noted that they were currently utilizing a telehealth model of some kind. We have those sites represented here today. And of those that did not have a program, all but 2 were interested in or are currently pursuing a telehealth program. Before we go much further, I want to clarify the nomenclature you may hear throughout today's presentations and discussions related to cardiac rehab delivery models. Of course, we have the traditional in-center delivery model. This is characterized by synchronous in-person sessions where the patient and cardiac rehab professional are in the same location when rehab takes place. Next, virtual delivery. This refers to sessions via synchronous, real-time audio-visual communication. In this model, patients and cardiac rehab professionals are not in the same location, but the professional is observing the patient in real time while rehab takes place. This is slightly different than the remote delivery model. Remote delivery is characterized by asynchronous communication. And in this model, patients and cardiac rehab professionals are not in the same location, and communication is occurring at times other than when a rehab session is actively occurring. Lastly, hybrid delivery refers to the use of more than one of these methods previously described. Most likely, this is a combination of in-center and virtual delivery, or perhaps could be a combination of all 3 models. We are going to primarily focus on virtual and hybrid cardiac-based approaches today. While MiCR was reviewing our survey responses, a major policy milestone occurred. On February 3rd of 2026, Congress advanced the Consolidated Appropriations Act of 2026. This legislation reinstated virtual delivery of cardiac rehab services from HOPD-based programs and extended Medicare telehealth and in-home cardiopulmonary rehab flexibilities for physician office-based programs through the end of December of 2027. And we are expecting this to be signed into law. This is a significant win for cardiac and pulmonary rehab and the result of years of advocacy at the grassroots and national level. So, congrats. With this extension, intensive cardiac, and pulmonary rehab programs in both hospital outpatient and physician office settings can continue delivering services virtually using two-way audio and video technology through the end of 2027. Back in 2025, we had seen some additional wins related to telehealth, including that CMS is now permanently allowing the requirement for direct supervision for HOPDs and physician offices to be met via the use of real-time, continuous, and audiovisual communications. And cardiac rehab codes are now permanently on the Medicare telehealth services list for physician offices. Now, as noted previously, that 2026 Act currently expires in December of 2027. This extended window gives programs the opportunity to launch or expand hybrid rehab models, try new approaches to reach patients who have difficulty attending in-person sessions, and plan with greater confidence while longer-term policy solutions are explored. If we do not utilize this opportunity, Congress and CMS may conclude that this is not a priority and the extension beyond 2027 may not occur. Based on our survey insights, combined with these recent policy changes, this will help MiCR's next steps and yours. Over the next few months, our goal is to share useful resources, highlight lessons learned, and create opportunities for programs to learn from one another as telehealth continues to evolve. Together, our efforts can help programs meet patients where they are and close longstanding gaps in access and participation. Our collective experiences can add to the evidence around telehealth cardiac rehab and help inform even longer-term policy decisions. And with that, I'd like to introduce our first speakers from Henry Ford Health. We have Dr. Stephen Keteyian, who's a member of the Bioscientific clinical staff within the Division of Cardiovascular Medicine at Henry Ford Hospital. He's also a professor of the College of Human Medicine at Michigan State University. He's joined by Kat Steenson, who's been a clinical exercise physiologist at Henry Ford Health for the last 5 years. She works mostly in the cardiac rehab program, where she has practiced both in-person and virtual delivery of cardiac rehab. She also works within the metabolic health department as a health coach and as a research assistant for several studies. So I will open the floor to Stephen and Kat. Could you please take a few minutes to tell us a little more about Henry Ford's cardiac rehab delivery model, especially your group virtual cardiac rehab program?
Thanks very much, Emily, and thanks to the entire collaborative for inviting Henry Ford to participate. And I'm just going to touch base at a higher level on a couple topics, and then maybe Kat do the same at a little bit higher level, but relative to actually delivering the service. Clearly, she does a wonderful job day to day with the actual delivery of the virtual component. So the couple items that I wanted to pass along as you think about moving this, and I understand this is a big paradigm shift for many of you. The first one is always keep in your mind that you want to make it as like your virtual program should be as like your in-facility program as much as you can. Forms, outcome measures, even times that you offer the classes if possible, but make it simple on staff so that's not a lot of rework in workflow. And while you're developing your program, keep in mind that we still have to deliver, we're responsible to deliver the core components of cardiac rehabilitation. So it's not just supervision of exercise that we're providing virtually, but also patient education, medication compliance, behavioral support. All this has to be done remotely. Now, it gets a little bit more difficult when you want to include some outcome measures, right? But some of those can be exchanged asynchronously through surveys, through MiChart, asking the patient to come in for their ITPs to collect data that way. So a lot of it is just thinking, using our brain power to think how best to do this, but we're responsible to deliver the core components. The second thing is, if you feel like you're on a little bit of an island, I encourage you to engage your physician support. We all have physician champions, big referrers, medical directors. Let them see the wisdom of what we're trying to do here, get them to buy into the idea. And then as you approach administration about wanting to do this and get resources in this area, let them help speak with you. I think that will help move the project forward. And then lastly, just in terms of a high level commentary, I understand that this is a black box for many of you in terms of how do we go about this. There's some fears about, we haven't run cardiac rehabilitation before in a virtual setting, and hopefully we'll get through some of those today. But with respect to billing and communication processes, rely on your billing department, rely on your virtual care or your telehealth departments, pull them in. They've got experience doing this stuff, especially as we've come through the public health emergency. A lot of this at-home work they've already worked through in terms of billing processes and connectivity. So rely on them along the way. I'm going to stop there with just one final comment is I can't speak for Michigan, but I have a feeling that they would say the same. But we're both here. We're here to help support you guys. So if you have questions, email us, pick up the phone, call us. One of the comments that Emily mentioned is absolutely correct, and that is we don't do this and use it, we may lose it in the future. So I want to leave on that thought. And Kat, if you want to provide one, two, or three high-level implementation ideas, that would be wonderful.
Yeah. So hi everybody, I'm Kat. Like Stephen said, our virtual cardiac rehab program mimics our in-person program as much as possible to help with staff burden, right? So that anyone can kind of step in to do these visits. I would say kind of the big, key takeaways. We deliver education on the same days that we would in person. ITPs or outcomes are done either during the class or, calling the patient afterwards to get that information that we need. We use Microsoft Teams to do our virtual cardiac rehab visits. And really just the key takeaway here is just going to be to mimic what you guys do in person. And that makes it a little bit easier transition when switching over to virtual cardiac rehab.
Great. Thank you so much, Stephen and Kat. All right. Next, I'd like to introduce our speakers from Michigan Medicine to speak a little bit about their program as well. We have Samantha Fink, the administrative manager for Domino Farms Cardiology. Sam has over 19 years of experience as a certified clinical exercise physiologist and 8 years in her leadership role. She brings a strong clinical foundation combined with a passion for operational excellence, process improvement, expanding patient access, and particularly all of this within the cardiac rehab service space. And then additionally, Diane Perry is joining us. Diane is a certified clinical exercise physiologist at Michigan Medicine. Right. We'll let Samantha and Diane take the floor.
All right. Thanks so much. So as Emily indicated, I'm an administrative manager, so I think about operations a lot. So we've had a really valuable opportunity over the past 2 years to participate in a research initiative for our virtual cardiac rehab. And we felt like this was our only opportunity to deliver virtual cardiac rehab since, as you guys all know, insurance companies were not reimbursing virtual cardiac rehab. So we went into the work hopeful that we'd be able to take our traditional model and seamlessly transition it into a virtual environment. But we've learned that it wasn't as simple as we thought. And so that's really what I kind of want to share with you guys is some of the barriers and some of the mishaps we had and kind of our vision for creating our next opportunity within virtual cardiac rehab. So while many of our patients expressed genuine interest and excitement about virtual cardiac rehab, not every patient was necessarily eligible or even set up for success. So, for example, we found a lot of patients didn't have reliable technology. So they would tell the study coordinator that they did, and then once the clinical exercise physiologist worked with them, they couldn't get on channel or they couldn't figure out how to get on the portal. So that kind of became a frustrating point, or patients thought they were healthier than they were. So, they would tell us that they could exercise a whole lot and they had exercise equipment, but once we went to that first session, we found they were lacking some of the basics to help with, some of the core components. And Diane, can get into a little bit about what Dr. Keteyian was talking about is the core components. I think our experience is we did a fabulous job, meeting the guidelines of reviewing the core components of cardiac rehab. It was just, getting to those first sessions and getting the appropriate patients. So without, some of those foundational elements like technology and exercise equipment, it did become a little frustrating for our teams to really ultimately, make these necessary changes. So our biggest takeaway so far is that virtual cardiac rehab shouldn't be viewed as a replacement for our traditional patients in a traditional program. So instead, I think we have a really big opportunity to reach out to a different patient population, specifically those that aren't able to attend cardiac rehab. So, our vision is to start thinking about those younger patients who have already went back to work or they're balancing childcare or aging family members and they're motivated. They have that exercise equipment. They do know how to exercise, but they just don't have the flexibility to attend those in-person sessions. So I feel like as we start to develop and move away from this research initiative, I think, having some of those, just a different approach. So knowing that we have to think differently about how we care for the patients. So a few things that we've been thinking about is, creating a very clear emergency protocol for those before and after hours. With the new guidelines, we can have a physician supervising virtually, but what does that look like before and after hours? And how can we implement that into our program to help reach those patients that cannot fit into that, 8 to 5 model? But then also, working with our referral coordinators for that structure to ensure that we have the right patients coming to us before that clinical assessment from our nurses to get us into the program. So while I've talked about, the challenges that we've faced, I really do want to highlight that we've had a lot of patients that we've been able to have meaningful success with. Once we've gotten the right patient into the program, we've seen engagement, we've seen that progress. And so, I'd like to kind of transition this over to Diane to talk about her daily experience with the patients and what those exercise sessions or coaching sessions look like with the patients on a day-to-day basis.
Thanks, Sam. I didn't know, Diane, did you have any comments to add to Sam?
I do, if you'd like me to, unless you have something, Jesse.
No, we'd love your comments. And I think one thing I just wanted to take a moment to point out for everybody, and I don't know if we were explicit about this, is that, the Henry Ford and the Michigan Medicine teams do slightly different models. So Henry Ford does group exercise over Zoom. So maybe at some point you can talk a little bit more about how you think about group size over Zoom, but I think my understanding is you typically do up to four patients virtually in these sessions. And then the Michigan Medicine team is doing one-on-one sessions with individuals. I think that frequency is different, and maybe you guys can both touch on that. But I know, Henry Ford, I think you guys try to model the 2 to 3 sessions per week, while the individual Michigan Medicine sessions are one session per week, but still both for a similar duration of 12 weeks. So I think that's an important difference. And Diane, maybe you can make a few comments now and maybe highlight things that you think about specifically too, as it relates to the individual sessions, where I think you have some unique experience.
Sure, thank you. Well, welcome everybody. It's great to be with all of you. I've kind of been working in this realm, not directly in cardiac rehab solely, but as a health and wellness coach, I've had some years of experience working more in a virtual setting. So just like Sam said, and like Dr. Keteyian said, we really want to hit those core components. So here at Michigan Medicine, the pandemic forced us into action but we had already been thinking about some of these things, because at that time we had about 2,000 patients referred annually to us, but only about 500 were actually enrolling because we had a large amount of them distance. And so we would refer them to places closer to where they were. And it got us thinking about how could we offer greater accessibility to them, right? But when we look at the virtual platform, it's really a focus on the core components, but also the needs of the patient. And we know that patients have diagnosis that qualify for cardiac rehab, but exercise affects that whole person. So we really have to take that whole person into consideration when we look at virtual exercise. So, fall risk, other comorbidities, like Sam was saying, their knowledge with technology, their comfort zone with technology, and accessibility to that. So for us, really, it was seamless in that we just decided to rely on the infrastructure we already had. So we utilize Epic as a way to schedule and create our Zoom sessions. That way we have a set encounter right there. So when we can move to billing, we'll be able to easily do that. Our individual treatment plans are done on a flow sheet within Epic. So again, we have that. We have all those resources with us, especially with the education side. The Michigan Medicine approved educational site for each core component is there, so we could draw in from that through the portal with the patients as well. So again, just thinking about the things that you already have available to you is so important to make this seamless and make it easier for your staff. Just like Jesse had said, we focused a little bit more on one-on-one. And I know we touched a little bit on looking at group, but we just had some issues where we couldn't get enough people to actually, patients to agree on the same day and time that they really wanted to be in a group setting. So we're a little different in that we do a hybrid approach. Personally, I find as a clinician, and I've been working in the field now for about 28 years, I find this to be a little bit better because it allows us to get a better look clinically at the patient. We do our initial intake calls. Our nurses do that to clear them for cardiac rehab. But we require them to come on site for, 2 to 3 sessions to actually have them on the monitor, observe them moving through the space. A lot of patients on the phone will tell the nurse, oh yeah, I can walk fine, I can navigate things fine, but they're navigating things that are familiar within their own home. And then they come out to Domino's and the first thing they say is, wow, parking's so far and I'm exhausted and it took me forever to get to the lobby. And we start to realize that they have some fall risk issues. So again, having that first assessment we find is very helpful. And then our patients go out to once a week calls up to 12 weeks with us. What I love about the hybrid is it allows us to pivot back and forth. So if I feel like a patient might have some issues that I would rather have them on site to see clinical changes, symptoms, if I want to progress their strength training and I feel like it would be better done in person to actually guide and show them positions, I'll ask them to come. We'll kind of work if they can come in on session, we'll do that. But it allows us to give that greater flexibility to the patient, which I know they really like. When I talk about the core components, big part of progression is behavior change. So this is kind of where I love the one-on-one, because in that hour I am observing them in exercise, but I can share in real time the same education, just like it sounds like Henry Ford's doing, the same education we're giving that week with the patients. I can share through the Zoom while they're exercising. And then I can also work on behavior change. I have longer time to actually engage the patients, identify their readiness for change. And then actually move through that progression. One thing we did do that's unique to the virtual for us was to create a template for how each session would look, so that when we're doing it, we're doing that template, we're filling in that exercise session, we're going through specific behavior change, letting them lead what goals they want to work on, setting those goals, and we can work from session to session to see that progress. And so we have found this to be very helpful. I am very interested in hearing from other groups that are doing group settings. We do that with our metabolic fitness program, but like I said, we have not really started doing that with the cardiac rehab at this time. But those are just some of the perks I can tell you that have really helped us give people that greater access to care. I guess the biggest thing is I will reinforce what Sam said, is that sometimes you'll start somebody, patients will want to do virtual out of convenience. But a lot of times they get in and realize maybe I am better suited to be on site. And we have had a few patients make the decision, I think I want to come back on site. So, it can happen. And that's what I think. It should always be patient led. But how wonderful is it that the patients now have options? I think that's great.
Thanks, Diane, and thanks to all of our speakers for those comments. I certainly have a few questions, but I wanted to just kind of pause for a minute and open it up to the group first and see if anybody had any questions as well. Well, I'll go ahead and get started with a question while folks think about it. And I encourage people to think about kind of the range of questions so they can be really detailed, kind of focused questions to kind of broad questions. So I think our speakers are here to serve as a resource. So I think our speakers have touched on this a little bit, but I think one thing I really wanted to hear from both sides is how you think about eligibility for virtual cardiac rehab. And I think that relates both to the medical conditions, but also the resources that may be available to them in their environment. And I was really curious too for the folks at Michigan Medicine too, maybe how that's changed over time as kind of a newer virtual cardiac rehab program. How do you feel like the needle has shifted over time from when you first started doing this a couple of years ago to where you are now? So maybe I'll have the Henry Ford group start and then turn it back to the Michigan side to make some comments.
Yeah, why don't you start? I've got a couple comments, but take a couple minutes.
Okay. So in terms of like enrollment or recruiting for virtual cardiac rehab, we usually recruit people straight from our in-person orientation. And so, we kind of see how they walk in, just like we would with any normal patient. But if they are eligible for cardiac rehab in terms of like insurance, I might dive in a little bit deeper into whether they have a smartphone or not. We have not really run into a lot of issues where people can't use their technology, or they have somebody at home that can help them, whether that's on an iPad or a computer that they can kind of set up by their equipment. The other thing is access to equipment. You want to make sure that they have access to appropriate equipment, of course. So whether that's, a treadmill, a bicycle, something seated if they need that. And then really the only other thing I would say is in terms of like getting patients comfortable with the platform, we do onboard them. So on their, first day, they would still come into cardiac rehab, maybe their first couple of days, just so we can monitor them and make sure that they're ready to go for virtual cardiac rehab. But we do onboard them in terms of downloading the app for them, showing them how to log in, showing them where the link is going to be. And we still do put all these appointments into our EMR as well. They're just listed as a virtual visit instead of in-person cardiac rehab. But we really have not run into any issues in terms of recruiting if people have all of these things. And the technology piece of it is not really a barrier from what we've seen for even like our older population, which has been pleasantly surprising. And yeah.
Thanks, Kat. Let me just add a couple thoughts. And the first one is I'd like us to think about for this patient population is casting the broadest net possible. And keep in mind that literally for 40 years, we've been asking our patients to exercise on their own at home. So this is no different than that. It's just doing it under supervision and in a little bit more structured educational and hopefully educational model. In terms of evaluating patients clinically, ideally, and we don't do this on all of our patients, ideally, I would like to get an exercise test done. And for many of us in the state of Michigan, we just don't have that in our workflow to get a test done. If you can get one done, then your ability to prescribe exercise off of that, better knowledge of what their exercise response is, all falls into play. If you can't do that, and it's rare that we get someone, if you can't do that, then I'm encouraging all of our patients that are want to go virtual to at least come in for 1, 2, or 3 sessions with us in the beginning, get a little bit of telemetry monitoring. If they're diabetic, we might get some we'll get blood glucose on them and maybe get a couple exercise or resting blood pressures as well. But we'll get to know the patient in that setting first before we say go virtually. And sometimes we've even had somebody who's gone through 2 or 3 sessions and in terms of connectivity and being on their own, we'll have them come back to cardiac rehab for their 4th session and totally ignore us. Connect with the staff virtually just as they would do if they were at home. But if they have questions about connectivity or if there's any other issues that come up, then we're right there to help answer to that. So that's an option as well. But you'll know the patient within 2 or 3 or 4 visits and then feel comfortable for them to do it on their own. And then they come back once a week, or once every 2 weeks, or once every 3 weeks for you to recheck on them that way. And then in terms of clinical characteristics, again, cast a wide net, but I will share with you that maybe some of the dialysis patients, maybe some of our LVAD patients, less there now, patients with very symptomatic and very low workloads, patients on milrinone, which is very rare. Except for those patients, we really want to get all of the patients into cardiac rehabilitation. And I'll share with you that in one of the trials we conducted, we did about 4,000 virtual visits, and we had one event. It was about 3 hours, within 3 hours after exercise. It was a non-fatal stroke. But so it's relatively very rare that complications occur during a session, and you would handle them just the same as you would most often if the person was in person. So try to cast a wide net and do a little bit of screening, but unless there's a pretty hard line on a reason not to exercise with you, and I rattled off a couple, try to be inclusive as much as you can.
Thanks to both. I know we got some questions in the chat. I just wanted to check Sam and Diane if you guys have anything to add to the conversation here, or if we just want to move on to some of the other questions.
I would just say I totally agree with what Henry Ford's doing. We're pretty much doing the same thing. And our patients don't really have a difficult time with the technology, that being Zoom and that they're used to telemedicine calls with their physicians. We have been using a specific app separate of that for our study. That has been kind of mixed back and forth in terms of patients liking it or not liking it, meaning having to upload data from a wearable that they might have or whatever. Some like it, some don't. But outside of that, the actual session itself and the technology to get on, we onboard them the same way, teach them how to do it so they're comfortable with it. And again, I would just say from a clinical perspective, not just clinically, but progression. So clinically, we do bring them in to look at them and see them. Of course, I'm always going to look. We do have some very high risk patients, and sometimes they're looking at it from a perspective of convenience, and there are some red flags that are concerning. The other thing is looking at risk for falls, looking at gait mobility. What do they have availability? I heard Kat talk about this a little bit, making sure they have the right modality of exercise so that they can actually see progression. If they have no equipment and they're, bone on bone, both knees, can't walk, have a poor gait, risk of falls, then what else is going to be happening for their exercise and to see that progression? I've had a few patients also when they self-report sometimes they think they're doing better than they are. And when we bring them in to update the ITP exercise progression from a cardiovascular perspective is not really happening because they're just doing chair mobility exercises. Of course, that's better than nothing. But again, core components, we want to see progression. Would they progress faster or better if they had the utilization of being on a new step bike over a period of a few weeks? So again, those are just some of the variables you have to consider each patient in giving them what they need.
Great. So I'll try to consolidate some of the questions and, keep asking those questions in the chat or raise your hand. If we don't get to all the questions, we'll be sure to reach out to you and kind of with some follow-up responses as well. So maybe I can combine a couple of the questions here. But one of them is, can your patients attend virtual sessions from a public gym, a senior center, HOA fitness center, anything outside of the home, or do they need to be at home? And then I guess depending on like where they're at, whether they're at home or one of these other sessions, like what are your emergency policies that you may have in case some of these issues arise afterwards? And maybe we can start, Sam, if you want to start, and then we can kind of move from there.
Yeah, we've had patients participate in cardiac rehab from like public fitness centers. One of the biggest things is right off the bat, we need to know exactly where they're at. What is their address? And what are some of the things, we might prompt them to say if you're having symptoms, is there a chair nearby? So I think that's one thing that we just have to take into consideration is what is their physical address in the event that we'd have to call 911. At Michigan Medicine, we do have a what we call like our red call or our emergency procedure process where we would page our cardiac rehab nurse who we would first connect with if the patient was having clinical symptoms. And thankfully, we've never had to go any farther than that.
I only add I'd like to put to that, Mike, is that if it's a Medicare patient, I believe Medicare is going to stipulate that the patient has to be at home. So that is per their statement. For Blue Cross Blue Shield and Health Alliance Plan, which are two other payers in the state that cover virtual cardiac rehab, then that I don't believe that stipulation is there. So a gym facility or, we had one patient who worked for AT&T, had great connectivity, and he would just walk the hallways at his office building. So it will depend a little bit by the insurance company. Kat, anything to add there?
Yeah, just to kind of reiterate, like if they are exercising outside of their home or even at home, you want to make sure you have their correct location of exercise every single time. We did have patients that maybe exercised at Planet Fitness one day and then the next day they would be at home. So you just want to make sure that you're really aware of where they are in case of an emergency. We too have never had to really do anything in terms of emergencies, but some of the things that I did like to have people do is if they were at home, like unlock their doors so that EMS could come in easily. Usually if they were like an older patient that needed more assistance, maybe with like their technology and stuff, just having somebody at home that could also help them or making sure there was a chair, nearby. another thing, just like we've said before, to mimic kind of what you do in person cardiac rehab. So if somebody was having symptoms during a session, making sure you're messaging their provider, monitoring their signs and symptoms, having them rest and seeing if, any of that resolves. And then if it were more of an emergency, our protocol was obviously EMS. We could also loop in our cardiologist to join the call, whoever was there. Or we would have like a designated staff person available to kind of put them in a breakout room and kind of assess the patient while, the other people were still exercising. But in terms of like a real emergency where EMS had to be called, the location was really important.
Great. Thank you all for that. I think I'll pivot a little bit because this was touched on just briefly in the last question, which is, how do you functionally bill for these sessions? I know that will likely vary based off of the payer. Is it using the kind of 93797 not monitoring for, non-monitoring cardiac rehab? And I guess kind of related, which is, I think, part of the kind of impetus for this is related to the Medicare billing in particular, because that may be the most the more newer way of doing this is, how are you guys navigating that? How is that going through your billing department, or how would you work with your billing teams to make sure that these sessions are being billed for accurately?
Let me just start, let others jump in, but I would say that billing is a black box for us, right? We didn't go to school for this.
That's right.
So rely on your billing people, and we've learned over time that a little bit of it's trial and error until we get it the way they want it.
Mm-hmm.
And what we do at Henry Ford might differ from what would happen at other institutions. But again, I come back, rely on your billing people. They've billed virtual programs before, and you can get this right. Don't view that as a stressor. We do use 939, the 97 code. That you do not have to have these people ECG tallied at home. There might be a specific patient population here or there that you'd want it, so fine, then go ahead and do it. But overall, you won't need it. We literally gave patients a pulse ox, finger pulse ox, and just use the heart rate information off of that, and then let them keep it. So billing should be straightforward, but it will and will be driven by the insurance company to an extent.
In Michigan Medicine, because this is a research study right now, we are not billing. However, we do have a team. They're called our revenue cycle liaison team that will certainly be, partners with us when we do implement this into our program outside of the research.
Yeah, I certainly would suggest and suspect that if you are curious about how best to bill for this, to reach out to your respective billing departments, and even providing them with, if it's questions around the Medicare policy, they may be fairly well suited to understand the language that's being used in that, and help navigate that appropriately. And this kind of some of the discussion leads into, I think, a couple of the questions here, which is, do you provide patients with devices? It sounds like pulse ox, maybe one of those, but are they given devices to attend sessions? Does it include a smartwatch with heart rate monitoring, or what kind of technology are you providing the patient? What kind of technology is the patient kind of expected to bring? And how is that kind of incorporated as patients are kind of using this form of cardiac rehab?
At Michigan Medicine, currently, we're not providing anything, but most of our patients have home blood pressure monitors that also measure heart rate. They also, a lot of them have some type of smartwatch. Or we're advising them on, if they're interested in purchasing one, on what to get. And then our sessions pretty much are, when we start, At least the patients I've worked with know right out the bat the routine, what's going to happen. They'll give me their vitals before we start. They're going to report their weight, blood pressure, and heart rate to me before we start. And then with those wearables, or if they have a pulse ox or any way, some of them have the treadmills that have the heart rate monitors on them. Then we're monitoring that throughout the exercise. And then the same thing that we would do in cardiac rehab on site, checking post vitals through those devices.
Yeah, Henry Ford, it was kind of the same. Ideally, like Stephen said before, we'd like to get a stress test before. So they do get a target heart rate range so that when they do use their pulse ox or their smartwatch or the treadmill or whatever they're using, they kind of know themselves where they should be at in terms of intensity, which I think also helps to have some way of getting your heart rate, but we're not necessarily providing like a specific technology. It's we did in the past give out the pulse oxes, which was helpful.
Wonderful. So I know we're getting towards the top of the hour here. I will put a call out if there are any other remaining questions for our Henry Ford and Michigan Medicine folks. Looks like there's one. As for stress tests, is it just treadmill only?
Sure.
Great.
You can also consider a 6-minute hall walk when you have them on site early on, if it's something, to kind of get an idea. That's something easily to reproducible at the end too, to see progress, especially in maybe some of your lower functioning patients.
Wonderful. Well, I guess, with that, I guess maybe I'll pose kind of a final kind of question or ask for some parting wisdom is, as folks are maybe considering trialing or starting some sort of virtual or hybrid program, are there some initial steps that they should take, whether it's talking within their program or talking with their broader administrative teams or operations teams? Are there kind of initial steps that would be helpful for them to take to kind of at least start the process that you think would be helpful for them to know? And maybe I'll pose to Stephen and Kat, and then Sam and Diane afterwards.
Kat, why don't you speak from the staff perspective in terms of, when this was coming at you, how'd you feel?
I mean, I definitely can understand I guess some of the worry when it comes to treating patients virtually, especially while they're exercising. But honestly, when you start it and you do it, even in a group setting, we had anywhere from like 4 to 6 patients at a time. It was honestly a lot easier than I thought it was going to be in terms of just getting everything set up, troubleshooting for patients, going through education, ITPs, all in one session. And it was actually really great. The patients do get to talk to each other a little bit more. In our in-person cardiac rehab space, the gym is a little bit larger, so they're a little bit more spread out. So I did see a lot of the patients kind of enjoy, even conversing and talking to each other or asking each other questions about their journey. But I think from a staff perspective, at first, I can understand the worrisome, maybe thoughts of like, how am I going to do this? What if something happens? But once you start doing it and you realize that it is very similar to in-person cardiac rehab, it really is a breeze.
And my only add, Mike, is that hospital administration now well understands, compared to years ago, the role of virtual or telehealth in the care of patients. So the environment is well set. I had mentioned earlier, find a physician partner, work with your administrators, develop the rationale and the business model to move forward with this. And I think it'll be fairly well received.
I agree with what Kat and Stephen just said. I just wanted to add that I think that everyone has to think about it as not just virtual, because each of us have basically said that we do more of a hybrid model. right? So the thought of just seeing a patient virtually from start to finish can be a little scary. But if you think of it more of like this is hybrid, we start the patient. If we have any concerns, we bring them back. So having that mindset, I think, can allow your staff that like ease of like, I have control over if I feel like this patient is unsafe, I can bring them back and we're not stuck in this virtual model. I think that will help move a lot of patients through this change management. And I think if you're a new program and you're not really sure where to start, I think you try to start with a healthy patient that's open to exploring with you. Ask them like, hey, let's put on a virtual visit, see how this feels, and take some of your experienced clinical exercise physiologists to start dabbling in what am I going to say to them? How is this going to work? And just see if a patient, will just work with you, knowing that it's not going to be perfect, but at least you have that initial experience that if you fail, they'll be okay with just helping you along the first steps.
Yeah, I fully agree with everyone. Again, it's really, you still have control of those patients in terms of being able to be with them, see how they're progressing, what's going on. But, in terms of the buy-in for your health system, also ask yourself, talk to the patients who aren't coming. Look at the barriers that are getting in the way. It could be transportation for them. It could be work schedules that they have to get back to work, and to come on site would be very difficult. And so having those numbers and being able to show these patients are being turned away because they can't get access. How can we make that better is a great way to get them, hopefully to buy into your program and help you establish something to get started with, I think is a good way to go.
Wonderful. Well, with that in mind, and as we kind of get towards the top of the hour, I just want to thank you all, Stephen, Kat, Sam, and Diane, for sharing your wisdom, and we appreciate you joining us and answering some questions. And my hope is that this conversation will continue to go forward. For those that are considering this, that continue to have questions, feel free to reach out to us. We're happy to continue to field questions and help get you the answers that you need. So with that, I'm gonna hand it back over to Emily here. And if you do have continued questions, please put them in the chat. We're gonna collect those and make sure that we get answers for everyone as well. So, but I'll turn it back over to Emily here to wrap us up for the session here.
Great. Thanks, Mike. And thank you again to Stephen, Kat, Samantha, and Diane for taking time out of their day to chat with us a little bit more about your programs. For those who are interested in learning a little bit more, or if you were, you know, looking for some other detailed resources and perhaps weren't able to attend one of the recent webinars on this topic, I've pulled together the recordings and slides from CEPA, Million Hearts, and ACVPR, who all held recent webinars on this topic. Additionally, there are in our slides today some additional links to toolkits and workbooks and articles that have been recently written about telehealth cardiac rehab. So I will be sharing these slides in a follow-up email to you. I'm also going to figure out how to share the recording of this discussion. So be on the lookout for that. And if you have any additional questions or suggestions for us, feel free to reach out. You can just reach back out to the email that I send our follow-up from.